So welcome. It's October 14th. The webinar today is about healthcare reform, the truth about political dynamics. Our star presenter is Ted Ball, who some of you know, and many of you will get to know through the course of this hour and a half webinar, where I'll have an opportunity to do a brief introduction of Ted, ask him to introduce himself, which will get him warmed up. And then I'll try and keep a harness on him to keep us focused and keep him under control. But his background is extraordinary, typically in the Ontario environment, but both public and private sector, very well-rounded, certainly outspoken, a change agent, if you will, as most of us are. And I think that what draws many of you to the webinars is to meet others with a similar background yourself, in the sense that you've been facing the challenge of institutions, bureaucracies, professions unwilling to change. And what we're going to discuss today is the lesson learned by Ted, and to some extent by myself as the host or interviewer, from success and failure for achieving patient-central health system reform. I know by scanning who is visiting us today that some of you remain actively involved, while some of us are, well, hardly retired. I think we're redefining the sense of just what retired means. So I welcome all of you. The topic is very contemporary, very challenging, somewhat generating anxiety among many, but we hope to have some impact and have a dialogue today, Ted. So Ted, over to you. You're on. Introduce yourself and tell us what you're all about.
Well, thank you very much. It's a very, very kind introduction. Maybe a little bit more. I can be introduced with many different kind of hats on, and I'll probably explain some of them. I think for the group that just introduced themselves, I'd rather start with the fact that I was one of the co-founders of a group called Patients Canada, along with a group of other people that founded it. And we spent the first about year and a half meeting every 2 weeks with lots and lots of patients, listening to stories, patient stories. And as you listen to the patient stories, you began to hear themes emerging, you began to hear patterns emerging, you began to see the systemic issues. And that was sort of what formulated the patient focused push that we did when we started. But we immediately, our spokesperson was Shalom Gluberman, who was really quite good and quite colorful on TV. And immediately, you know, in addition to the big spokespeople for the doctors and the big spokespeople for the hospitals, there suddenly was a patient voice in a very articulate Shalom Gluberman, who was sort of telling the stories. And so what immediately became apparent is that patient-centered care became flavor of the month overnight. And what was interesting is watching people push aside Patients Canada, as you know, ministers of health, certainly in Ontario anyway, created their own patient advisory council. The Health Quality Ontario created its patient advisory council. All the different organizations began to do that. And so patients became quite popular, but it was popular not to do anything of significance, but for tokenism. Now let me put on another hat. In another hat that I wear as the partner in quantum transformation technologies, which was rooted out of an organization called Quantum Solutions, founded in Austin, Texas, that did systems thinking tools and invented integrated systems thinking tools for designing integrated delivery systems. And we did 23 integrated delivery systems. And one of the things that we were really good at is we had one of our people was Art Forworth, who was the former head of Disney's Imagineering Corporation. And I don't know if any of you have ever been to a Disney theme park, but Art and his gang, Art was a certified genius who was both an engineer and a psychologist. So you will recall that as being left brain, right brain. And Art and his team designed the customer or the client or the visitor experience at all Disney theme parks worldwide. And when I would go to events that Art would facilitate, he would ask people, have any of you been to a Disney theme park? And a number of people would put up their hands, and he'd say, now at the theme park, you saw somebody in costume, and you're probably wondering, so that character in costume was the highest paid, most sought after job. Can you think of what it might have been? And so most people would say, oh, it was Donald Duck, it was Mickey Mouse, it was Goofy, or whatever. And then Art would reveal it as, no, it was the sweeper, right? The sweeper on the park, in the Disney theme park, was a guy in white overalls, carrying a broom, and would bend over and pick up pieces of paper and put it in the garbage. But that person had been trained extensively in human anxiety and body language, and they were trained to recognize people who were in anxiety. They could read body language, because Walt Disney had said this was to be the happiest place on earth, and you can't be happy if you've got fear or anxiety. So their job was to remove fear and anxiety from the park. So if you were wearing anxiety on your body, and they would come up beside you and say, excuse me, mister, can I help you? And you would say, well, I lost my kids, or I can't stand my wife, or whatever is causing you the anxiety, but they had to deal with it. And many other tricks of the trade, instead, if you were going to be in a lineup for 10 minutes, you would find out that unbeknownst to you, a number of things would happen all around you that would distract you, so you didn't really notice the 10 minutes. What Art did when he finally left the Disney Corporation is that he had two things that he really hated in life. One was being a patient, and the other was being a student. So he took the methodology for patient experience design, or the customer design methodology, and applied it to patients and students. And so I worked with Art through 23 integrated delivery systems in the United States that we did for a lovable little firm called HCA Columbia, which in those days I think was a $300 million a year operation. And through a very simple methodology, which was patient-driven, because it's patient experience co-design, which incorporates the patient, their family, the professional caregivers, the nurses, the physicians, whoever you want to have on there, because what they're going to do is they're going to be examining the journey as it went through the path, figuring out what went well, what didn't go well, and as they map that out, they would then at the end say, collect all this. Was a great big on a map with great big color pieces of paper, and somebody at the end would pick up all the little purple pieces of paper and the yellow pieces of paper and then read them off. Here are the things that patients didn't like. Here are the things that nurses didn't like, blah, blah, blah. And you'd hear all of that. And the leverage question for healthcare management and everyone else was, if we didn't like those things, what could we do to get rid of them? And then similarly on the yellow pieces of paper, the things people really liked and valued, what could we do to get more of that? Through a very simple system, there'd be a massive change in the system, structures, and processes in that organization that would result in a surge, a measurable surge, significant surge by multiple points, teen points of patient satisfaction, followed by a surge in staff satisfaction, because they're co-related, of course. And so that's the other point about the patient experience co-design. Well, everybody was after patients to come on, be on this committee or that hiring committee or advisory committee. The reality is that most of that stuff ends up being tokenism. And if there's one thing I've learned from my patient experience and from watching healthcare reform, is that the only thing that's powerful, that works, certainly in the 23 integrated delivery systems, which, by the way, is about those are decentralized delivery systems in which you're trying to create a seamless patient experience across the continuum of care. And the moment I say that, I'm now into the field of design, system design.
So
Yep.
let me interrupt you there. So
Yep.
in a centralized system, you've got authority. The system is basically held together and driven by that single mindset of whoever is in charge. And I can recall personally being in a department where the minister wanted change, and it was easy as could be. You snap your fingers, you got what you wanted because the minister ran the show. In a public health system such as we have in Canada, with authority sitting sort of at the federal level, at your provincial, you have a top-down mindset. If you can get that top-down mindset committed to patient change, you should be able to see it occur. But it appears we can't. We've had premiers in Alberta claiming healthcare reform that were totally ineffective. So I've been in the environment where the senior official, the minister, was 100% behind it and things happened. But I've also been in organizations where that person couldn't make change themselves. So politically, we've got extraordinary rigidities built into this, whether it's the professions, whether it's the reluctance of the patients to speak up. You've been in there, you've heard over and over again that there's going to be change in Ontario. Has there been change? I mean, we can bring Disney in and all of his friends and have Mickey Mouse run around all day long. And I'm not sure that's going to bring about change unless we can figure out, whether it be authority or a revolution by the patients themselves or some new technology that everybody's got to pay into. What the hell is it going to take in Ontario? Because we haven't figured out in Alberta.
So first of all, you named a couple of people there that really were running governments. Very rare to find those kinds of politicians anymore, but certainly the minister, I worked for 2 ministers of health in Ontario and wrote speeches for another 2. So I ended up being a policy speechwriter for all 3 political parties. And that's because the commonality in those ministers were that they were progressives trying to make real patient-centered reforms that really excited me and made me want to be a part of what they were doing. I look back at the last 15 years in the province of Ontario, and we have had ministers of health that do not run the ministry. They are script readers, and they're set up by their bureaucracies. And the bureaucracy, which is nominally named the Ministry of Health, is not the Ministry of Health. It is the Ministry for Hospitals. That's how it thinks. That's how it behaves. And we're real good at hospitals and high-tech hospitals, and we're real good at healthcare processes like open heart surgery and cancer and all the other tech things. We're not very good at children's mental health. We're not very good at mental health. We don't do illness prevention, health promotion. We've de-emphasized through the years. Primary care. What am I talking about? Primary care is falling apart. We've put it, well, because it's just not exciting, right? Family doctors. The bureaucrats that run our ministries for hospitals have really focused on a very narrow thing that does not produce much. Here in Ontario, and I suspect I'm not sure sort of which direction to go in here, because you've given a couple of themes there, one of which is centralization versus decentralization. And my comment there, when I mentioned the ministries of hospitals, Ministry for Hospitals, they're also ministries for bureaucrats, right? We have now seen in Canada a powerful bureaucracy that tends to serve its own self-interest. Let me give you for example. The federal government is now transferring $1.9 billion to the province of Ontario over 10 years for mental health and addictions. You know where the money is going? The bureaucrats put the money in creating a center of excellence for mental health and addiction and a new division of the Ministry for Hospitals for mental health and addictions. And so we've probably created about 200 high-paying jobs. And now, meanwhile, children's mental health waiting lists have gone from 18 months, which is what they were in 2018, to 40 months today. So that's after the feds have given us all this money and the bureaucrats now, I'm just using that in healthcare as an example. The Ontario, we have a place called Ontario Health, which has been around for 4 years. And in those 4 years, it has hired 2,500 public servants. These are bloated bureaucracies that are designed to command and control the system. So if you want, one more thing. 30% of all the expenditures in our healthcare system and in your healthcare system in Alberta, 30% of all the money that we spend, and here we're spending $81 billion annually, 30% is wasted or unleveraged spending. That's a great deal of money that can be redeployed to buy all the kinds of things that we need, like home care. And go ahead. Yeah.
Yes, I'm going to interrupt there because these discussions can often end up talking about organizational structure, the amount of money, the number of jobs created. All of these things seem to be appealing to politicians to talk to the public about. We're providing more money, we're creating more jobs, we're building more bureaucracy. None of that discussion is about what's happening to the individuals on that waiting list. What is happening to those that have been referred to hospital again because of therapeutic misadventures? Seems to me the discussion is on the wrong thing. It's as if we are a country still building a healthcare system instead of transitioning it from the building days to the service days. Service seems to be overlooked. Care seems to be overlooked. The plight of the individual supposedly for whom the system was established are ineffectual. We have in Alberta 25,000 nonprofit societies. How the hell do you build policy when you got so many special interest groups funded by government? So David, you in Minnesota, here's a couple of quick lessons. If you want to bring about change, authority is necessary but insufficient. So you've got to make damn sure whoever is in charge of change is 100% committed. Absolutely not going to buckle to under any other special interest group that's claiming, well, tinker here and tinker there and make sure I'll give you some votes. So that's fundamental. But as you've pointed out, Ted, it's got to be more than that. You've got to have frontline, bottom to top change. And that means changing your people. Because what we have today is administrators. We'd have managers. Administrators committed to the status quo. They're not managers. I think we have a system that is really not being managed at all. It's being maintained.
Yeah. Let me make a comment with regard to centralization versus decentralization. And, if I was running the system and my old minister Larry Grossman was running the system, I really like that centralized command and control. I'm in charge and I know what to do. That attracts me. However, experience in life tells me that there's not many Larry Grossmans, there's not many Ted Balls, that we can't wait for heroes. What we really need is, my judgment is, decentralization of power, stripping authority away from centralized bureaucracy, devolving authority, particularly for money, devolving authority to local organizations, which can allocate resources based on what their local priorities are. So rather than centralized bureaucracies, and I know that in Alberta, you're like a yo-yo. You go from centralized to decentralized, from centralized to decentralized. I think if you look over time, although maybe somebody knows it here, but my sense is that the wisdom of people at the local level always outshines the brains of our brainiacs at central control headquarters, in our capitals and in our bureaucracies. And
that's the objective of decentralization, is to ensure the system is sensitive to more regional or decentralized issues. So it supposedly removes that overlayer of power, allowing the influence at local levels to have an impact. The dilemma often is they become rogue.
Right, but your Alberta Medical Association doesn't want to deal with all those decentralized organizations. It wants to one throat to choke, right? And so all the other interest groups as well. So the interest groups and their bureaucracies, and the bureaucracy and the government itself, are kind of colluding together, and that's a very powerful network of power.
Okay, so tongue in cheek. So the system is being managed by the suppliers. I thought the system was built for the patient.
No, you're right. We are dealing with a supplier designed system. It's not a patient designed system. It's a provider designed system for the benefit of providers. And whatever you can squeeze out, there's a lot of tokenism, particularly now, and optical illusions. But no, it is absolutely a provider driven and provider oriented delivery system.
So you could argue that that's exactly what you expect when you're building a system. When you have no system at all, 100 years ago, we didn't have a health system, or even till Tommy Douglas came along. Now we have something, but at some point in time, leaders need to emerge that transition that supply orientation to one that is focused on the individual. And I'm afraid that that's really what this story is all about. Why is it, or how can we achieve it, to get the patient to be what this system is supposedly built for? By the way, Dale, I think you're up in Minnesota. You've got your hand up. Unmute, if you will. Let's hear what question or point you want to make. Unmute.
Yeah. What I want to say is, as I listen, what you're saying is two major things. One, the patient focus, center focus is not there as the driving force. And then secondly, whether you're a bureaucrat, whether you're appointed, whether you're elected, nobody is managing the healthcare system from some kind of, Don will like this, I hope, framework. What are they managing? According to what? Some systems knowledge. They come in there, they have it's what I had in the public sector. We have people appointed who has never managed an organization before, then on top of that, manage a system. You've got to have, if you're going to institutionalize this stuff, meaning it sustains itself over and over, centralized, decentralized is sort of irrelevant. If you're managing a system for the patient, does the patient care whether it's centralized or decentralized? No, they want service. So who?
Okay, but let's pick up on that, Ted. I think yes, they want service, and if they're not getting service, what choice do they have in a monopoly? None. And so when you talk about decentralization, can you also talk about the introduction of competition? Can you talk about the introduction of options and alternatives? Can you talk about the introduction of new technologies that empower the patient with knowledge that was once exclusive to the professions? You want to pick up from there, Ted? Because it seems that, like it or not, whether the professions like it or not, or whether the government likes it or not, the patient is becoming armed with biometrics as wearables. They're becoming armed with internet, with ChatGPT. The technology that's emerging today seems to be in the interest of giving the individual who the system was built for more influence. Or am I wrong?
So organizational scientist Deming, very famous guy, just before he died, and he was working all the way through to about 85, looking back at his career, looking at dysfunction in organizations and in systems, came to the conclusion that 93% of the time that he saw dysfunction and chaos, it was due to the design of the system, structures, and processes, and 7% of the time it was due to the people. Now, he said on the people side, the 7% people side, half the time, 3.5%, it was due to lack of training, and 3.5% of the time it was due to bad people. So we tend to really zero in on bad people. Oh, it's those dumb doctors, it's those CEOs that aren't well. But when the reality is, it's system design that's driving system behavior. And if you want, so every system is perfectly designed to produce the outcomes it produces. It's perfectly designed to do that. So in Canada, for example, Perry, you used the words therapeutic misadventure. In hospitals, we call them preventable deaths and preventable accidents. And so there was 25,000 preventable deaths in hospitals in Canada last year. 25,000. That's like loading up 3 jumbo jets of people and crashing them every day for a year, right? And if we witness that, we'd say, my God, what's happening here? So what we've got are very dyslexic, dangerous systems that are not patient-centered, but they're designed that way. They're perfectly designed to achieve that. Until and unless we redesign these system structures and processes to be patient-centered, to be safe, and to do all the other things we want. It's called designing for outcomes. Nothing will happen. And as you pointed out, also nothing is going to happen unless we've got, we need leaders. Let me say one thing about leaders. There is a total absence of leadership anywhere in the healthcare system, except I see the odd patient group now emerging. I'm working with a group in Ontario called Senior Citizens for Social Action. A very research-oriented group that is really, causing some stirs. But I don't see much happening out there, or that's giving me much hope about the future of healthcare in Canada.
So let's pick up on the patient. As you know, and we talked about it this morning, I had some experience in the deinstitutionalization process, which was heavily resisted by professions at various levels and locally by those communities that in fact benefited from the jobs, the local jobs of those institutions. What inspired me personally, and I had a leadership role, so I'm going to talk about this just for a moment. I was inspired when I heard of Geraldo Rivera's video where he had walked into an institution of 25,000 people. It was inhuman. And he commented at the end of his video where he had said, I've shown you what it looks like. You've heard what it sounds like, but I can't tell you what it smelled like. Now that might be extreme because people are only dying. It's not smelling. That's what's happening in some of our institutions. These huge complexes needed to change, but it wasn't going to come from the top. The revolution that occurred in Alberta that I think was successful is because parents lined up and said, enough is enough. And when the government did ask them why they are therefore on a waiting list for an institution, do you want the bed today, tomorrow, or yesterday? They didn't say today or yesterday. They said tomorrow. Then why are you on the on the list? Because we heard there was a shortage. So waiting lists play to the hands of the supplier. And that therein lies one of the most manipulated tools that the health industry has today is, oh, obviously we need more of what we have. And I don't think that's what the patients are asking for.
Right. Let me describe, there's a system design in Alaska called NUCA, the NUCA system, N-U-K-A. It's put together by South Central Foundation. They are a First Nations healthcare system in Alaska. And Perry, with simple language, the language that everybody who comes through that door is called a patient owner. Okay, a patient owner. That changes the whole idea that you're not being, and understand our colleagues from the United States don't own their healthcare system. They purchase insurance. In Canada, we own the system. In NUCA healthcare system in First Nations, they own the system. But the mindset changes really quickly when everybody in the healthcare system is labeling you a patient owner. You're a patient owner. Uh-huh. Rather than being treated in a paternalistic manner, you are given the, and so owners, you own that hospital, you own this system, right? So it's a tremendous mindset shift and that puts real power. But, again, that's called a leveraged action because it's done with just simple language, changing the mindsets of how people in the system relate. And right now, patients are not treated as owners. They're not.
Well, the dialogue continues to be all about supply. It's about jobs. It's about more money. It's about more facilities. It's about more technology at the top. But is patient satisfaction relevant to the system's change? Does anything that we see indicate that we have a collective voice of patients that's going to in fact be able to challenge the professions that are interested in maintenance of status quo? I see Peter Fenwick's made some comments, and we're going to be calling on Peter to be sitting on a panel when we wrap this up at the end of the month. But I'm going to read something that Peter's put up on the chat, and he says that in Alberta we've got multiple systems changes. We've seen leaderships change. We've seen private-public changes to cut costs. Not
Harry,
for
you
the
want to
betterment of patients.
give Sydney that credit? Give Sydney that credit. That's Sydney's text.
Oh, we'll fix that in a minute. The more you gave it to us, so I'll give you credit for showing it to us. The more changes implemented by successive governments, the higher became the cost, the worse became the patient experience, and that it's time to talk about revolution. So that's what this dialogue is all about. We've seen, or I've seen, 50 years of talk in mental health and in health about changes necessary to focus on the patient, and yet we still have this bloated. Now, the article goes on to read by Peter Hutchinson in Minnesota, by the way, Dale, and he wrote in 2004, just a little while ago, the price of government is getting the results we need in the age of permanent fiscal crisis. Nothing like a crisis to bring about change. Pull money out of the system, reduce the number of jobs, decentralize, depower the infrastructure. A decade of experience had produced a proven set of strategies. In speaking to Hutchinson, he said, a vision of zero-based budgeting with citizen service woven in goes a long way because it adds the patient to the value base in terms of how you allocate your resources. That's called market forces. When we were talking about empowerment of the patient, we were talking about giving them knowledge, which today is exclusive to the doctor, empowering them, which changes the nature of the client-patient relationship to giving the client more influence than the professional, or at least equal influence where the professional needs to listen. Peter, anything you want to add there?
I think only to say that we do our best, but our best is not good enough. And there's a lot of experimentation that happens that never scales.
We do our best for who?
Well, it depends on who the we is.
Well, I mean, that's my point. I want to take what you said and sort of take it apart a little bit.
Yeah.
The we has been the supplier. We do our best for supplier. We do our best for the voter. We spend more and then claim that we should be getting credit as a government because we're spending more money.
So what I liked about Hutchinson and Osborne's and Gaber, Ted the Gabler's work back in the early 90s.
Yeah.
Thanks. Yeah. Thank you, sir. It was kind of based on a number of things because you had was it Blair and Michael Barber working on results tables in the UK. You had Osborne and Hutchison looking at reinventing government through some very entrepreneurial principles in the US. And there were some elements of success, but it's like there needs to be a political, capital P and lowercase p, willingness to do things differently with structured rigor. And Ted knows this better than many, perhaps. People make systems.
And Peter, I finally found the solution because there's answers out there, and they're in the hearts and minds of the frontline healthcare providers.
Right, frontline.
One of the techniques that we learned from Herbert Wong and Quantum Solutions in Austin, Texas, was a complete set of methodologies to how to tap into the collective intelligence of the people who work in the delivery system.
Yeah.
And so through a whole set of methodologies, and what you've got to do is be humble enough to say, the answers are not at the top. If you want to pay your CEOs $500,000 or $1 million a year, go ahead. However, they don't have any of the answers. The answers are in the hearts and minds of the people at the front line. And they don't know that they have the answers because not one of them has the answer on their own. It's collective intelligence and the practice of dialogue and methodologies called transformation that can absolutely facilitate remarkable transformations of organizations. I've seen it happen. I've seen organizations that were producing, really bad data on all of the key performance indicators, go through a transformation over a 3 or 4 year period and begin to produce, top results. So, but they're doing that on the basis of the brains of the organization, not on what some smart guy in the Capitol thinks or some new CEO that, is got fancy or some consulting company. The knowledge of what to do and how to fix is in the front line.
Yeah. So Ted, and I guess Perry, you want to be careful because I know there's a panel that you've got scheduled for the end of the month where Ted and I might have some of this conversation. But after 15 years at GE, which was the first third of my career, Ted, we called it workout, and it was about letting the frontline staff solve their own problems. But when we layered lean on top of that, it was lean through the lens of the paying consumer.
Look, we've done some research. Ted and Peter, we've done some research with frontline staff. They were told you're not allowed. You're
Yeah.
not allowed. When the cell phone first emerged, the mainframe computer was challenged. The institution was adamant that you're not going to be allowed to have cell phones. We said change will come, but it's going to come from the front line sooner or later. But those waiting lists have to build, and that pressure has to build till the thing explodes. Don, you had some responsibility to try and introduce innovation in an organizational structure where we all hoped or believed that innovation may well be the vehicle to give those frontline staff the opportunity to make a difference. You want to add anything here about how easy it is to bring innovation to bear when it's going to have positive impact on patient outcomes?
Well, thanks, Perry. So I've just linked myself to some work with this fellow, Dan Berznowitz, who won the award for the publication of his book, which is called Innovation in Real Places. He's at the University of Toronto, and in that book, he's identified the structural impediments, and it's not just healthcare, it's the Canadian economy generally that has been somewhat hogtied in being able to facilitate the innovative behavior. So part of that is based on the ownership of patents, for example. We do extremely well, as pointed out, with the University Health Network being one of the top organizations on the globe in terms of medical innovation. But in respect to actual economic spin-off and development, and Peter Fenwick and I have discussed this at great length, we have a lot of challenges converting that intellectual capital and creativity into economic production. It migrates out of the country into other locations very, very rapidly. So there's that challenge. There is also this challenge of the strength of the Canadian government is that it has a publicly funded system that is based on a budgetary process, based on estimates that come out of Treasury Board to allocate funds to their servants, the suppliers. And of course, those are based on some pretty rigid expectations on the delivery that's to take place from them. And of course, that, as was pointed out earlier, in 1948 was to build an acute care system in the country that was going to be second to none. And I think one of the leading politicians in Ottawa calls the contemporary problem with primary care delivery and 6 million Canadians without a family physician, really the tyranny of acute care, basically starving out every other element. So innovation in the area of acute care is fine, but when it comes into the other areas of secondary or primary care, very, very difficult. And of course, that's because we have an electric fence between the budgetary allocations that have taken place. And so Peter and I would have in many instances looked at, well, wouldn't it make sense to reallocate resources from the operating room into home care so that we could look after patients at home? Well, there was nothing that actually annoyed the surgeons any more than anybody asking them to give up money to do something else, because they've already got a huge lineup to do things. So there's all kinds of incentives and disincentives in the system to actually make changes based on the structures that we've got in place. So that's just two examples, but I would highly recommend looking at Brezinowitz's book. It really, I think, might have a couple of suggestions for where we might go.
Well, I think that the point that you've made, which was an excellent one, is the issues that we're discussing today in healthcare are relevant to virtually all public sector institutions, implying that Canada has been in a building phase. For the last 100 years, we have been building our public sector services, whether it be in education or healthcare, corrections, you name it. Interesting, some of the massive fallout of those systems is what we see in our alleys today called the homeless, which is the fallout of these failing transitional systems. But you mentioned knowledge capital. And I think a point that I just made about we are so enamored by the words knowledge that we give PhDs to professionals. We create huge institutions called universities, hospitals, healthcare systems, all of which are empowered with knowledge. So we love the word knowledge. We will know. And you as clients are one step above a slave in Roman times. So the power structure has been with those that know, or in those institutions that know, and those that are enslaved to that are called patients. That's the way the system was built, which you pointed out. But when is the system of building going to transition to the system of service? Well, what's very interesting is ChatGPT and education has emerged where the patient is no longer that dependent client. They are becoming empowered by the fact that they have knowledge, or they believe they have knowledge, which creates the complexity in itself. So it seems to me the transition, or this flip from the power at the top to the power at the bottom, is moving to a point where the patient begins to become a market force. And that scares Canadians because that sounds American. That's one of the impediments to change is, oh my God, it's going to look like the American system.
There's another market force coming into play, which is called the baby boomers.
Yeah.
Oh, and so the baby boomers, and you're probably on the leading edge there, Perry.
Oh, I passed that. I passed that ages.
But in Ontario, we had a minister of education called Bill Davis, who would eventually become the premier. But he was the minister of education. He saw that baby boom, and he started building a network of schools, grade schools, then high schools. Then ultimately, he was in the Ministry of Colleges and Universities. He was building colleges and universities. Then that baby boomers were now producing babies. We needed hospitals with lots of obstetrics, and then everything was geared to what that population wanted. Now we sit there, we don't have adequate home care. We don't have a big emphasis on the kinds of things that maintain us in independence. Instead, we've got bloated bureaucracies and a lack of investment in the kind of things we need. When I watched what's happening with this organization I just flagged to you, which is called the Senior Citizens for Social Action, I think they're on the leading edge. These are consumer groups of citizens, senior citizens, that are now demanding. Now, and remember, each of us has probably been paying our provincial taxes, maybe $10,000, $12,000 a year annually for our entire lives, right?
So
how much
are these seniors, are these baby boomers you're referring to, which would be a socio-demographic force versus a technology, for example?
Yeah.
Are the socio-demographics saying these seniors want more institutions?
No,
Did we learn anything from COVID? And yet we're building institutional structures to warehouse seniors.
Right, and this seniors group, and I think more seniors group, is going to fight that. Seniors don't want to be in these large institutions. We put bank robbers in large institutions called jails. Stop putting the elderly in large institutions. There are many creative alternatives that are not big institutions. And as you just said, did we not learn anything from COVID? The answer in our province is no, we've learned nothing. We are building 7-story nursing homes now.
One of the interesting consequences of a phase of institutional construction was what happened when the Lazar houses were not needed anymore in the Middle Ages, when the first institutions were created. When it was solved and they were empty, they went to community to find others that they could solve their problem and bring them into institutions. And Michael Foucault writes about this. He calls from back wards to back alleys. And there's my fear of what happened in mental health. And I think my allusion earlier to whether it be the criminal system we talk about, those that aren't succeeding are going to find themselves in the alleys. And that alley, I mean, San Francisco is facing it today, and we're beginning to feel it in Canada, that something is failing and the evidence is in the alleys today. And my fear is to solve that, we're going to put housing first, and it isn't going to matter how big those houses are. The bigger, the better, because we're going to be cleansing our communities again. And seniors will be the next wave.
Yeah. So you put your finger right on the exact problem that we've got. All of those homeless people living on the streets are just standing in line waiting to arrive at the emergency department. and then ultimately into an acute care bed, all because, so we're going to have, multi-billion-dollar healthcare problems on our hands caused by homelessness, when supportive housing is the inexpensive alternative to avoid all those costs. But as I said before, our ministry for hospitals, right, want to build more hospitals. They're not interested in supportive housing, in a couple of units here and a couple of units here. That's not very exciting. And the minister can't go and cut the ribbon on a supportive housing apartment, right? So it's just not exciting. And yet, and here in Ontario, we had a commission on hallway medicine, and they recommended to the government of the day, to the same government, to the Ford government, to invest in things that would divert patients from hospitals. So a simple, by investing in community-based mental health, you save hundreds and hundreds of millions of dollars diverting patients who would have gone there. By investing in primary care, you end up diverting people away from the hospitals. So
diversion is a form of triage. Let's talk about emergency wards. You made reference that earlier, that the homeless, because they don't have a doctor, go to an emergency ward because they've got a cough, a sore throat, or they've got more than a hangover, that's for sure. But when they show up in the emergency ward, they sit and they wait. And they wait. And I've sat there in the last year, at least 3 instances, for 18 hours, 12 hours, 8 hours in 3 different facilities. And I looked around the room to see who, it wasn't the middle class in those rooms. These were people with sneakers and baggy pants. And they really didn't need a doctor at all. They probably could have had a nurse. And they could have been in and out of there within an hour if nurses were allowed to see them first. So that's a form of triage. Yep. And yet there were those with the emergency medical vehicles, the ambulances, they had to sit around and wait until the doctors were available. Well, when we finally got into a cubicle, there were 7 doctors outside the room. What were they doing? Entering data into the computer. That was the priority. Yeah. So one of the things driving this appetite that I have for healthcare reform was that very experience, that the frustrations of those that have experienced what waiting rooms are all about and the nonsense should be up in arms, and the politicians should be listening to them, not the doctors. We didn't need more doctors. We needed triage. We needed nurses. We needed someone to see these people and give them a handkerchief or give them an aspirin. And I'm not saying send them all home, but for God's sakes, let's talk about service and talk about people, and do a service satisfaction when you're done. When was the last time they ever did service satisfaction surveys for their quote patients in that system? Peter, you got your hand up.
Sure, I'm just going to ask a question instead of responding to anything.
Go ahead.
Ted, can you please comment a little bit on Ontario Health Teams? And I'll add a little further flavor to this. There's a history behind OHTs that predates, and Ted can tell us a bit about Helen Angus and Matt Anderson's first experiment with that when they tried doing triple aim in 2013 before Helen became deputy of health. But there is a link in the chat that I have placed when we were talking about Alaska earlier. Ted was giving an example, Nuka in Alaska, and the whole idea of owning your own health and actually having a stake in it cooperatively, shall I say. We did create a health cooperative in the city of Airdrie where 62,000 people were meant to be owners of their own health. And that was not able to be scaled for various political reasons, but I did include the website there in case anyone was curious. So Ted, I'll come
back and ask you why it wasn't successful.
Yeah, that's, I guess, lowercase p political and probably a topic for a different day. But what Ted will remember, because he was in my office in Whitney Block, in Toronto, the only thing that I had on the wall, Ted, was the poster of the Airdrie Health Cooperative, because I was attempting to influence Helen's design of OHTs to be far different than it turned out. Can you comment on its evolution in the last 3.5 years, please?
Well, yeah. So first of all, I'm a huge, huge supporter of devolved healthcare systems like Ontario Health Teams. That was to be the intent. Um, but uh, unfortunately, the Ontario Health Team was designed to fail, right? It doesn't have any of the ingredients that you require for minimum specification for success. And so it was handed this wishy-washy, empty-minded mandate that was built on another previous that you're talking about. I think you were referring to HealthLinks, which had just squandered the same kind of misalignment, lack of framework, not understanding best practices for organizational design, and entering into the equation was a mindset for command and control. So in the original architecture for the Ontario Health Team that had the deputy of the day all excited, was she said it was a single point of accountability, right? Meaning that one throat to choke management philosophy, because she wanted to have the CEO of the hospital become the CEO of the local healthcare system. So the very sad thing is we're dealing with an idea which is decentralized integrated delivery systems. And Perry, you just made reference, an important thing, to the social support systems that we never pay attention to, right? While we're squandering and wasting 30% of our money in healthcare, we're underfunding all of those wonderful community support organizations. But when you bring them into the same architecture, so you have devolved local systems of health and social service providers with a single pocket of money to be allocated locally based on what their local strategy is to achieve their vision, you're going to see major reallocations of resources from current being spent on care into social supports.
The principles of deinstitutionalization, or that transition from a point of permanency to one of independence, was that the dollar followed the patient.
Yes.
We use buses to dump people into alleys.
Yeah.
In fact, the principles were prepare the person, prepare the community, and develop the service infrastructure before you deinstitutionalize, as opposed to dumping, which simply was a prerequisite to bringing them back again. Now, Jeff, you made a point. I think we should visit it just for a moment, because he's got to leave shortly. When you talked earlier about people at the front lines, the doctors, the nurses, whether in education, they care about the plight of the individual. And yet when they get together collectively in their union, they're all about supply, protection, and maintenance of the status quo. So we have a dilemma here. We've got people who actually advocate and would like to see real patient-centered change, but the system is being driven by the influence of them as a collective. How the hell do you break that? How do you break these trust busting? I don't know whether anybody's got an answer there. Yeah, go ahead. You got your hand up. Let me hear Dale's comment. Dale, unmute.
I would say it's similar to what I faced in Minnesota and the state of Florida, where I worked in the public sector, where we had a lot of unions. In Minnesota, it's a very unionized state. You go to Florida, less so. But the focus on terms of institutionalize this is first have that vision and your mission that drives the organization, whether it's from the citizen standpoint when you're dealing with government or the public sector, but that drives everything else you're going, so that you eliminate, minimize the need for a union. Why are unions there? Because they can't get along with management. They don't have a common ground by which you communicate between, in the case of healthcare, the nurses, the patient, everything. There isn't there. So they come together as a collective. Well, that's why these were put in place. So if you've got to create that sense of common commitment from senior leadership through the organization. So it's not a we-they situation. We at the top tell others what to do, and then they've got to collectively bargain.
But the political dynamics in a socialized health system is the votes are with the negotiator who supposedly is negotiating on behalf of the people, which is the minister. And if that minister cares more about votes, which he's going to get from doctors, teachers, and nurses who carry large numbers, he seems to be leaning more toward the supplier's interest than he is toward the patient's interest. Democracy is in a mess in a socialized system. Ted, you want to pick up on that? Or Jeff,
Well,
maybe Jeff will
I
make
would
an
also I would like to point out that some of the suppliers are confused themselves. So let's take the medical suppliers, right? They negotiate with the government for a fee increase. And they believe that doctors are really need lots and lots of more money. And the problem is that our doctors are absolutely miserable. They're absolutely miserable. And so what I can tell you, having watched this for 30 years, is every time the doctors come into the negotiating table, they walk away with a lot more money than they arrived at, year over year over year over year over year, making constant gains, and not once has those massive increases in wages ever made them happy.
Well, you talked about money flowing into the system and never reaching the front lines. We saw that over and over again.
My point here is that the issue is, why are doctors unhappy and why aren't we dealing with that? So the College of Family Physicians just recently put out data that said 40% of a family health doctor, of a primary care physician, 40% is being spent on bureaucracy, right? Filling out forms, right? Now, if you go to the root causes of all of those forms, you've got bureaucrats back at the ministry saying, we'd really like to ask doctors this question and that question. And that way, if we ask this question and add these 3 questions, we could make a really great pie chart. And so now we have 40% of the time of our physicians. Now in Ontario, we have 2 million people that don't have access to a doctor.
Right.
If we wiped out, say, 30 to 40% of the unnecessary bureaucracy faced by physicians, we would end up with happier docs, because they want to make they're not making any money when they're doing bureaucratic work, right? And that's 40% of their time. So they want to be meeting with patients. That's what they were trained to do. So suddenly, if we were to get rid of unnecessary bureaucracy for family physicians, we would be able to have a family physician for every citizen that's seeking one. And meanwhile, there's the Ontario Medical Association pounding the table saying, we want more money. We want more money. No, we've got miserable doctors. We want happy doctors.
We want happy doctors. We want happy patients. The doctors are more than prepared to make that happen. And yet the overburden seems to be working in a different direction. It's an oxymoron. It's astounding. It has something to do with organization and this appetite for socialized medicine and this fear that allowing the patients to speak. I'm fascinated with some of the changes that are going on in the world of technology, stem cell therapy, biometrics, and genetic and generative AI. All of these seeming to giving the individual the opportunity to personalize their own health, which scares the hell out of some of the system that says, no, we don't want personalized health. We don't want the patient taking charge of their own healthcare. We want precision medicine where the supplier is still the ones responsible, even though they're not accountable. So technology is giving us opportunities, like it or not, where the individual is becoming more and more influential about their own healthcare and becoming more of a partner in healthcare with the physician than simply the patient, a client. Okay, go ahead, Peter.
Biology is one thing, and being able to do a 23andMe self-pay search is one thing. And whether that ever fits within the Canada Health Act's purview of only paying for what is necessary medically versus curious by the consumer is a different thing. And when we first started, because I think many of us not only have a technology background, but remember things like this. You're going to laugh. And given the audience, Danica, indulge me for a second. You ready?
Oh, wow.
yeah. And that wasn't the first version, was it?
No, no, but I still have the analog antenna.
Yeah.
Right. So communication wasn't originally about technology. It was about finding a way to speed up and at volume learn from multiple transactions.
Mhm.
There are simpler solutions in other part of the world that allow for the front line to communicate with each other outside of the medical legal system, which is litigious in nature, and it requires us to capture documents for potential risk avoidance, as opposed to actually listening and using that for meaningful co-design or redesign.
Mhm.
Perry knows that I'm on the board of Imagine Citizens Network. It is an organization slightly different from Patients Canada, but with the same, I think, kind of spirit, with an Alberta focus of looking at the role of citizens in not only navigating the healthcare system by making it simpler to understand, but also looking at the voice of citizen in being reflected through healthcare reform. So we had a voice at the table with the primary healthcare reform that was just written and given to the new minister based on the previous minister's work in the spring. And it's called MAPS, M-A-P-S, if you want to look it up. But the point here is we are in the process of raising money as a not-for-profit to buy and license a communication technology from the NHS in England, where the tool itself is used as a third party to collect data. Call that conversations, opinions, perspectives, experiences at the front line, patient reported, shared with providers without the bureaucrats, if you will, getting in the way. And I have to be careful. I mean, I'm a former bureaucrat here, right?
Yeah.
But I'm also somebody who understands the private sector quite well, having started my career there. It's the blend of knowledge and insights that come from legitimate customer discovery and listening, which is what Ted talked about when he first started with the HCA experience, and the incentive and the accountability to actually do something about it. And that may or may not happen within Alberta acute care, but it certainly could happen in primary care or continuing care.
I think what's interesting, and Yogi, you might want to jump in here, is if that data is being captured and digitized, you have the opportunity to put it through an artificial intelligence filter to see what changes might take place. I saw last week, I was shown a wearable that does biometric monitoring of everything from glucose to cholesterol to heart rates to heartbeat. I mean, gathering data is one thing, but that device actually had integrated into it generative AI.
Yeah,
Which told the patient, which told the diabetic patient that you are within your limits, and this is the dietary adjustment you should be making if you're exceeding that. So that is empowering the individual to actually be engaged in behavioral change using generative AI that has looked at millions of similar data points to help that individual manage their. That is a threat to the profession.
Absolutely. So Perry, let me jump in since you asked me to. There's a couple of things. Data gathering is okay, but the minute we get into diagnostics and recommendations, I understand the wall goes up in turf protection on the part of the physicians.
And privacy gets raised.
Well, gets raised as a red herring. Let's be very clear about that. So back to the data question, we don't have to get to the fancy technologies of generative AI. We can do this with very vanilla, well understood data analytics. The issue always is the underlying compatibility or incompatibility and the variation in data quality in the data that makes the conclusions suspect when we get to them. And so the way you address that is through an incredibly boring subject called data gathering standards. Nobody wants to take time out to talk about that. And when you look at the fact that the physicians all get to make their own choice about the systems that they operate within their clinics, and those systems are all incompatible, and the example of the 7 doctors who were busy being data entry clerks that you gave, the data quality that comes out of these systems is of dodgy quality and of income is incompatible. making all of the value that we could get from them very difficult.
Yeah.
Now, AHS, of course, thinks they're going to solve this with this giant system that they're rolling out for hundreds of millions of dollars. And I wonder whether that's going to be the case. Peter, you were trying to jump in there with your microphone.
I was trying to give you an accurate number. I think the ask at Treasury Board was 1.2 billion, and it's exceeding that.
Yeah. Well, and they pulled
Thank
out
you.
a system some years ago that IBM was building that cost $1 billion, and they closed it down. So $1 billion
Yeah.
here, $1 billion there. Does it really
So-
make a difference?
So I think what's going to happen here is what Perry mentioned is these wearables are not just going to do data collection, but they're going to do diagnostics and recommendations. And this is going to be a revolutionary end run on what the physicians see as their protected turf.
Yeah.
And where that will lead, I'm not sure.
Man,
Well,
go ahead.
The other point about the diagnostic AI thing is that they've also embedded into the artificial intelligence empathy, so that patients are sitting there going, boy, that experience, that's the most empathetic doctor I've ever had, not really understanding that was AI working, not a real doctor.
No, it's coming. And all of the discussions we're having about organizational change in politics, I think we're going to be having that conversation 50 years from now, but technology is going to beat it all down. I think arming the patient is probably where the revolution is going to come from.
I think the combination of technologies, whether they're artificial intelligence, the metaverse, a whole variety of
Even stem cells.
Cells, is such a revolution. We're really talking about, moving from the phone that Peter just held up to the internet. Okay, there's been a lot of change in the way we think and behave and do business since his instrument that he held up and today's world.
Well, it should be increasing efficiency for sure. It should be increasing effectiveness, I hope. But we're placing an awful lot of hope on the fact that our politicians are not who we trust taking us there. They're caught up with the special interest group. Let's hope that the patient armed with technology, thank you IBM, thank you Microsoft, thank you Sam Altman, that's where the change is going to come. We've heard promises in the past, but it was always empowering the physician or the supplier because they were the buyer.
Yep.
This technology appears to be low cost.
Yep.
Anyone want to pick up? I'm looking for a hand. Dawn, I was extremely impressed with the background that you provided me with of your interest in this particular topic. Have we missed anything in particular that you'd like to hear a little bit more of, or a comment you want to make?
Yes, I would like to say a few words, of course, Perry. I think I like to go back and think about root cause, about how do we create healthy people in our society, right? And I think that our health system is broken for a reason, because we've moved from years ago having homeopaths and naturopaths and a prevention healthcare as part of the way we maintained our health, and we've moved into an institutionalized bureaucratic system that's looking for problems and prescribing pharmaceuticals like there's no end in sight, which create a real vicious cycle of ill health. So I would say let's take a look at that. And the other point I want to make, just building on the good points about Deming and systems thinking and that sort of thing, is that we know what works. We know what kind of management system you should have in a hospital or a doctor's office or what have you. We know what works. For some reason, we don't have the will to implement it. And I think that what gets in the way of that is the politics and the egos. And so I think we need to take a real, good look at that, because if I take a look at high performing healthcare entities around the world, they're out there. And I know that by asking the people working in the system for their ideas and suggestions and their innovations, that will contribute to 90% of improvement. But the other 10% will come from looking outside and learning from others that are doing a really, really good job. So the NUCA system that was mentioned, that's based on the Baldrige excellence model.
Yep.
And, you know, and all the excellence models we've got out there are really good. That's my area of specialty, right? And so we know when we work with organizations using excellence models, and we've found a really simple, straightforward, time-efficient, cost-effective way to do it. We know when we get everybody contributing to strengthening an organization and being actively a part of that, that wonderful things happen. So we do that kind of every day. We know how that works, and we know it works really, really well. And it's just a matter of training people and involving them in a bit of a self-assessment of their organization, and then engaging them in the things that need to be done to improve it. And a lot of it comes from the people. I mean, consultants, get out of the way. You know, really, it comes from the people doing the work, because they know best how to improve it. But you have to give them a really nice model to begin with, to work with, and then train them and get them engaged and involved in making sure that it's all in place. So,
in principle, you need to add something further, because simply using the words training and excellence isn't convincing me. You've got to bring in the word patient and results at some point. And if that's what you're saying, excellence from the perspective of getting results, then I'm all for it. I hear you.
And Perry, in terms of you know, in terms of the model we use, I mean, we're looking at governance, leadership, the customer, or who is the patient. We're looking at the employees, the suppliers and partners, the resources that you use, the way you measure. And we're making sure that we're taking a look at all of this. And when we do assessments and we ask the employees in an organization to weigh in on what's the current state of the organization, you know, to what extent do they have these things in place, we get back these ratings and open-ended comments that give you such a thorough feedback on the system. And right from there, there's your roadmap forward in terms of what you need to do to strengthen it. And then best case scenario, you get everybody involved in that, you know, so they're doing the work, they're building the system, is their system at the end of the day.
So Dawn, are you confident that if I put you in front of a minister of health to give that little speech that you've just given, he's going to say, wow, I'm all in tomorrow? I don't have anybody that's going to get in my way, because that's truth.
Well, what I would say is that what Dawn just gave us was wisdom, right? And I see she's got silver hair, and I understand people with silver hair have lots of wisdom.
Look, if you had any hair at all, I'd be.
Well, yeah, that's. But let me give you share the formula for wisdom. Those of you who've got a pen, you can write down wisdom equals, right? It's the formula. Wisdom equals knowledge plus experience plus reflection minus ego.
That sounds like ChatGPT in spades.
Yeah, well,
every one of those features is exactly what we are now seeing with ChatGPT. It has experience, it has knowledge, it's all there.
Yeah, and reflection is about creating the learning, right? And that produces wisdom. Insight.
Yeah, I see a hand up, Dale. If you take a crack at wisdom.
Okay, just to endorse what Dawn has said, what we did in state government, this is in Florida, we would not go to the legislature if we had to, or to the governor and say, okay, we're going to wear this framework stuff on our sleeve and we're going to walk in. We walked in with what you said, Perry, results. We went in and said, we can give you much better results than the private sector can bring you. We had people that would say, yeah, get rid of government, make it private. Private can do it better. We came in and said, we can get you. And we proved it with results to the point they went out and did financial auditing. They got an auditing firm to try and beat us. We beat them. So we said, we're going to bring you results. how we did that. If they wanted, we would open up the hood, show them what we got. But we get in there with the results.
So
And
I would be pleased, and I'm sure every citizen in Alberta or Canada would be pleased, if a politician were to stand up and say one simple thing regarding result. I guarantee you, I will shorten the waiting list.
Yeah.
right.
Those with waiting for hip surgery, those waiting for knee surgery.
Yeah. So is that the right? I challenge the metric.
Go
I'm
ahead.
not saying results is the bad thing, but is that the right metric?
I'm just, give me one metric. I'm not going to argue as an academic over whether it's right, left. Let's get on with one of them instead of having this boring long-term discussion about getting it right. Let's just ready, aim, ready, fire, aim. I'd like a little bit of that.
Yeah.
What metric would you throw on the table? Give me one.
So Don is the better metrics person than I, but I would suggest it's a population health metric in some, which is where it gets back to the triple aim.
I'm not interested in public health. I'm interested in personal health.
No, but Perry, it's a bottom-up number. It's a sum accumulation.
Give me a number. Dawn, what number would you give? What metric would you put on the table and say, I, as a politician, am going to stand up and fix one thing? What would that one thing be?
Oh, that's a different question, Perry. I thought we were talking about healthy people.
I'm looking for a metric that is illustrative of a healthy person.
Wow.
I think we have to look at quality of healthcare, and we have to look at patient satisfaction. We have to take a look at employee satisfaction, financial results.
That's not patient satisfied. I want to see a waiting list reduced. Patients fed up with waiting.
I have one other thing I think is important to say. Years ago, when I was the chair of the Quality Council of Alberta, we did a mini conference, one-day conference, and we brought in 4 different groups from healthcare. And each one told their story about how they were using, the systems I'm talking about to improve their department in the hospital. And one of them was wait times, actually. And it was absolutely amazing. And really what came out of that conference is, number one, all the healthcare people there said, we have to do this again. But number two was the doctors that were very much a part of this, working with their staff to make improvements, said we had to push our ego to the side and get out of the way and let our employees provide input. Those were 2 big takeaways that day. And it just shows it can be done, and it shows real people doing the work and getting results.
You think you could have done the same thing with patients?
Oh, absolutely. And I mean, part of this is involving the patient, involving the suppliers and partners, all the stakeholders, because they're taking a look at, let's say, the work processes and what's going well and what needs to improve. And so you're getting them all involved in the conversation, and the patient, of course, very important. The patient's involved because patients will have a lot of input, a lot of good input on how things can be improved too, and very valuable feedback. It's absolutely amazing when you gather all this feedback.
The Alberta Medical Association has been doing the same thing for years, bringing the collective together to come up with what might be done to make things better. And what is the typical answer they get? More money.
No, it's not more money.
I know. I'm just saying that. I'm talking about when you bring suppliers together. I'm glad to hear that properly facilitated, they will come up with recommendations that will make a difference that patients will see and patients will understand.
So Ted, welcome to the mélange. What is your metric?
Who are you asking?
Our speaker, our guest speaker.
Okay, that's what I'm coming back to. We got about 5 more minutes, Ted.
So I don't know if I'm being Ontario-centric here, but right now it feels to me that the most important metric right now, where there's panic out there, is 2 million people with no access to a primary care physician,
right,
which results in a massive overflow into our hospitals and into the most expensive. So my metric would be to have every citizen have access to a primary care physician. We could be pressing buttons like, let's grow, quadruple the number of nurse-led primary care clinics, nurse practitioner primary care clinic.
Could you say, Ted, could you modify that somewhat and say we guarantee every Canadian will have access to a nurse?
Yes. Well,
why does it have to be to a doctor?
Well, yeah, I think every Canadian will have access to primary care.
Right.
Right. And so it's a team of people. It's a team of people.
Sure.
Right. So the other thing, going back to Peter's question about Ontario health teams, Peter, one of the things that I think made the 23 integrated delivery systems in the United States work so well is that the hub of the system in each case was primary care. And so the hub became the patient's medical home, and their job was to manage the entire process, right? So when you empower primary care, that is a move that's to take structurally, and it's not about the doctors, it's about the patients.
Has anyone tried that in Alberta, Peter?
Yes, the Airdrie Health Cooperative.
And what? And I mean, from what?
No, seriously, there are 35 family doctors, 10 of which were brought in from outside.
Sure.
I had signatures from 25 of the 35 family docs that work within the Highland PCN who are interested in a salary-based, non-fee structured alternative payment model to allow them to do better care, to not be chasing around nips and ticks and little tiny slips of paper that allowed them for 5 minutes here, 10 minutes there, but actually not run the business of primary care, but provide better patient care. Like there's a whole model behind this, behind the Abrio Health Initiative, citizen-driven, citizen ownership, primary care focus. We were attempting a new deal with the health authority. The Tom Baker Cancer Center was to have a satellite in Airdrie so that the east part of the city was actually covered, and you didn't have cancer patients coming from all over central, like southern Alberta, to serve the machine and the mountain that's now been built on Foothills campus. It's distributed.
So in a webinar about political dynamics, we have just heard one of the answers to better patient care and outcomes is primary care networks. Why, from a political dynamic point of view, do we not have more primary care networks?
Well, it's actually not just about PCNs, right? And we had to be like, the language is not about payment reform. It's about innovation.
I may got the language right, but you're telling me that we did something right and something that should have been replicated and should have been the engine for change, and yet you told me they closed it down.
Yeah.
Did it have anything to do with political dynamics?
Yes.
End of our webinar. What the hell is wrong with the politician who supposedly owns the system on behalf of citizens, seeing something that worked on behalf of citizens, and yet not buying in? I don't understand. There's something wrong with socialized medicine. There's something wrong with this system that does not listen to the positive results that have come out of the front line about how to make a difference and bring about reform.
Can we end, like in basketball, you want to end on a shot that actually goes in the net? Can we end off here?
You get next to last, not a last, Ted, to give us his closing.
Okay. When I was raising money for Abrio Health, which was previously the Airdrie and Area Health Benefits Cooperative, structured under the Cooperatives Act of Alberta, I was in a room full of impact investors from across the country. And one person stood up after hearing my pitch, and his name was Bob McGinnis. And some of you may know Bob. Bob said to this crowd full of people, I knew Tommy Douglas. My dad was his driver. And when he would come back from Ottawa and need to drive around the constituency to talk with people, my dad would drive him. And on those Saturday mornings, Tommy would come into my bedroom and kick my ass out of bed. And I would learn things from him. And Bob said, if Tommy was in the room today, he'd say the same thing he said in the 60s. Healthcare is broken,
right? But
it's our responsibility to go fix it. Do something.
Ed?
Thank you very much for that. My final conclusion is to recap Deming. 93% of the time that we have dysfunctional, dyslexic systems is because of the design, not because of people. We don't have bad ministers, bad deputies, bad CEOs. We've got a horrible design of a system. Peter just talked about a primary care design that absolutely makes sense. We need all of those kinds of designs that we know that works. And I don't think we need net new knowledge about some kind of new invention. We can patch together from lessons learned all over the world a Canadian version of an integrated delivery system that's seamless, that's high quality. We were just pointing out about, here in downtown Toronto, we have access to some of the highest quality open heart surgery available on our planet. We can be doing that on all aspects of healthcare without spending more money by investing in community and all sorts of things to divert traffic away from our very expensive acute care hospitals. So it can be done. I think the knowledge of how to do it is right on this line right here. I think everybody's got a little piece of the answer. And I think this collective wisdom will emerge ultimately.
Well, I want to thank you all, Ted, obviously, for your insight and you're stirring the pot to get us going. It's been a rich discussion. I'm glad we got input from a number of the viewers today. I think this could go on easily for another hour. And as we come to wrap up, if you don't want to hang up, we'll end the recording shortly. But if you want to hang around and keep the discussion going, you're more than welcome. My takeaway is it's time to reform the system. And it's going to have to come from the top, or there's going to be a revolution from the bottom. If we don't move from a public health system to a personalized health system, I think we're going to have a huge problem. And I think there's evidence that problem is before us today. So hopefully the politicians are listening who are the owners, because at some point in time, the voters are going to have enough frustration and the waiting list will grow to the point that there will be a shakeup. And in what form it will occur, who knows? But technology says you're not going to have to go that far. We may be able to solve the problem at the point of the patient themselves. So that's one of the promises that's out there. You can wrap it up today from a point of view of recording, Claire. You'll see his right arm go, and that